I'm going to talk fast. There's a lot of information, and I tried to cut out some slides from my normal sort of hour-long talk, and I struggled to do that. So I may not go quite into as much depth as some of the information on the slides, but I do want to try to at least touch on a number of different topics because there's just so many really important issues that our patients and ourselves will be facing. So I'm going to go over today a little bit about what I like to call the chief complaint, which are some of the problems with our current system, and then get a little bit into the policy versus the politics of what's happening around us. And if we have enough time, talk a little bit about the role of students and physicians and nurses and all sorts of different healthcare professionals in this effort as advocates. So as I'm sure many of you know, we have some pretty significant problems in our current U.S. healthcare system. We have around 47 million people uninsured. That represents about 15% of the population, and 81% of those people are in working families. So this isn't the true poor. Most of those individuals are able to qualify for Medicaid. Most of these are pretty hard-working middle-class folks that just can't get access to insurance for a variety of reasons. One of those reasons is that employer-sponsored insurance rates are falling. So in the year 2000, 66%, 66% of non-elderly Americans, so people who are under 65, don't qualify for Medicare. 66% of those folks were covered through work in the year 2000. By 2009, that was down to 59%. And that's been for a whole host of reasons. Employers have been dropping insurance coverage because it's so expensive. And then added on top of that was our current economic situation, which has caused even more employers to find offering health insurance just too expensive. Another problem that our patients face is something called underinsurance. And what this means is that people have a health insurance policy and they think that they're covered. But then when they actually get sick and go to use it, they find out that, ooh boy, a whole bunch of things are not actually covered. One of the examples that we hear somewhat frequently are people who have these catastrophic plans. So maybe they need surgery because there's a suspicion of a tumor, let's say. And the policy covers that because that surgery, that event is considered somewhat emergent, kind of falls into that catastrophic category. But then that tumor is found to be cancer, something that's going to require months of treatment as an outpatient. And that's not considered catastrophic. That's not an emergency. And so those treatments may not be covered or be very poorly covered. So that's an example of being underinsured. And this number, the percentage of people that are whose bankruptcies are affected by this is controversial. People argue about it, but there is no doubt that a number of bankruptcies in this country are related to being underinsured. Now, from society's view, healthcare in the United States is way too expensive and is of insufficient quality. The United States leads the world in per capita spending on healthcare. So what that means is, if we do the math, in 2009, if you took the population of the United States and you divided it into healthcare spending, the United States spent about $8,047 per person in this country on healthcare. That's about 24% higher than in the next highest spending country. So take any country you can think of, any of the European Union countries, and we are way above them on a per person spending. Now that might be okay if we've got really incredible results from that spending, but the problem is that we don't. People argue also about World Health Organization rankings, and we can argue that until we're all blue in the face, but the bottom line is we're nowhere near the top 10. We're not even anywhere close, no matter how you do these numbers, on any of these fairly important items. And this is a great article that was, let's see if I can get this little thing out of here, that was published online in August at the Urban Institute and the Robert Wood Johnson Foundation. And this was an article that, it's a really accessible, easy to read article compared to a lot of the stuff that compares quality. And they were really looking at the data out there about where the U.S. is in terms of being the best in the world. And here's what they found. This is just a short paragraph from the conclusion. The authors found that there's no hard evidence that identifies particular areas in which the United States healthcare quality is truly exceptional. Instead, the picture that emerges from the information available on technical quality and related aspects of health system performance is a mixed bag, with the United States doing relatively well in some areas, such as cancer care, and less well in others, such as mortality from conditions amenable to prevention and treatment. And this last part would be of no surprise to anyone who does any type of primary care or is interested in primary care. In fact, we spend very little on prevention or primary care in this country, and the current euphemism in Washington is that we actually have a sick care system, not a health care system. And what's meant by that is we don't really invest at all in keeping people healthy in the first place. We wait till they get sick, and then we spend lots of money trying to get them, restore them back to health. Now, many people feel in this country that it is way too expensive to deal with all this healthcare reform, and we really should just leave us at the status quo, or maybe tinker around the edges a little bit. But so I want to give you some information on what would happen if we did nothing. So in the year 2009, the U.S. spent $2.5 trillion on healthcare reform. So that's an important number to remember, $2.5 trillion. Because the cost of the current healthcare reform bill that all of this argument has been about for the past year is just under $1 trillion over 10 years. So in 1 year we spent $2.5 trillion, and that's been escalating every year. And the bill that we've been having all of this discussion about is just under $1 trillion over 10 years. So that puts into context that it's actually a pretty tiny fraction of our total healthcare spending. And that $2.5 trillion number is up 5.5% from 2008. And that's been about what we've been seeing for the last 6-8 years, about a 6% increase in healthcare spending year to year. This represents a little over 17% of the gross domestic product of the United States. And the portion of that is paid for by public sources like Medicare, Medicaid, Veterans Administration, etc., is up about 8.7% and is now at $1.2 trillion. And then private payer represents the rest, and you can see it's up only about 3%. Part of what's happening with this public payer growth is that in 2009, a tremendous number of people who lost their employer-based insurance, if they could qualify for Medicaid or Medicare, took advantage of those programs and shifted over to public sources of healthcare financing. And that's reflected in there was an actual decline in enrollment in private plans. And the expected growth continues for the next decade out, about 6% annually, which is 1.7 faster than the expected growth in the gross domestic product. And public payers will cover over 50% of healthcare purchased in 2012 because of this escalating growth. And that does not take into account that we don't pay income taxes on our healthcare benefits that those of us who do get it through our jobs get. And if you took into account that really tax-free benefit, the government is already paying for about 63% of healthcare in this country. What about on a personal level if we do nothing? Well, in 2008, the average family health insurance premium was $12,298. And at current rates of growth, if they just stay stable, by 2020, that same policy will cost $23,842. Accelerating in cost way more quickly than wages are actually accelerating. So it's not like we're going to be able to keep up. It's going to be relatively more expensive by 2020. So much so that it's estimated that the amount of uncompensated care, so people who don't have insurance, would double in 45 states by 2019 because people would simply not be able to afford health insurance. It doesn't take a whole lot to change this growth curve. If you could slow premium growth by even 1.5% or even 1% over this time, by 2020 that would translate into $2,500 of savings or almost $4,000 worth of savings if you were able to slow that growth by 1.5%. So how did we get to this crazy mess? Well, this country has this idea of individualism as its core. You know, this country was founded by many people who were fleeing oppressive governments, and they came here so they could do their own thing kind of pretty much unhindered. And that approach and that idea has been an underpinning of our current healthcare system, such as it is. And there's been a constant tension between the role of government in this system and the role of the individual or the marketplace in creating the healthcare system. So that brings us to today, and that's the scenario that we're faced with. We've definitely got a very well-defined problem, and we're hoping now that we're looking at a window of opportunity, that we can actually get something done about this problem. Now, Kingdon is a sociologist who studies what components have to be in place to actually affect major social change in the United States. And he describes a situation where three things have to come together to actually cause that window of opportunity to open. the three things are that you have a well-defined problem, which I think we do, that there's the political will to do something about the problem. And I would say, despite all of the rhetoric, that members of both political parties agree that we actually need to do something about our current healthcare system. There's not actually disagreement on the fact that we need to act. The disagreement comes into what is the action. And then the third piece of this is that there's a policy solution that is willing to be supported by enough votes in Congress that it can actually be turned into law. And that's where we run into trouble. And there are many questions about the policy solution and what it should look like. They're philosophical and practical. The themes of this were featured prominently in the 2008 presidential campaign. And they come down to, at a very fundamental level, this question: is healthcare a privilege or a right? And I'm sure everyone in this audience has an immediate answer to that question, if they think healthcare is a privilege, or if that society has some obligation to its community to make sure everybody has access to care. If we walked out onto Locust Street and stopped 10 people, they would also all be able to tell you exactly how they felt about that. And how do you think this comes out in this country? What percentage of people do you think believe that healthcare is a right? Any thoughts? Oh, come on, somebody can make a guess. How much? 60%. 60? It's actually 50%. And 50% feel that you're on your own. Pick yourself up by your bootstraps and figure it out. And it really doesn't matter who you ask that question to. Physicians have been asked this question, and for the most part, they come out about 50-50 too. So it's just one of those things, and that's part of why we struggle and have so much acrimony over this issue of how to get healthcare reform done, the actual process of it, because people are pretty evenly split in the United States on this most fundamental question. So the answer to that question then drives all sorts of policy solutions around how to solve the problem. So for instance, are costs best controlled by market-based solutions, like just put it into the free market, or is there an increased role for federal government necessary? Is this an individual responsibility, or does society have some responsibility? And then we have a whole host of very, very contentious issues that has just been ripping Congress apart on both sides of the aisle. And these issues tend to transcend which party you're in. One is whether or not undocumented persons should be covered by this plan, or only American citizens or legal immigrants. And the second one is about reproductive rights and whether or not there should be further tightening of rules around abortion services and federal dollars around that, or if the status quo is acceptable. And these things are just ripping the bill apart to some extent. So the last time that we had an opportunity to try to get this done was in 1992, when President Clinton and then Mrs. Clinton were working on this problem. We had a pretty bad problem then, although not nearly as bad as it is today. Lots of political will. President Clinton was very, very committed to solving this. And the problem came up in terms of the policy solution that was created. President Clinton put 100 people into a room, a lot of policy experts and others, and told them to put together a plan, which they did. It was developed largely in secret. There wasn't a lot of consensus building among the stakeholders. And then President Clinton delivered this plan to Congress, and Congress said, whoa, this is big, this is complicated, we didn't write this bill. You're expecting us to make difficult votes on this bill that we didn't write? And they sort of threw up their hands. The pharmaceutical industry, the private health insurance companies just piled on with negative advertisements, and very quickly, actually, that bill had failed. So President Obama took the completely 180-degree approach to this. He simply articulated a set of principles in early February, shortly after the inauguration, and then he told Congress to go ahead and write the bills. So this was a strategy that he hoped would sort of keep everybody at the table, keep the insurance industry, the pharmaceutical industry, and everybody at the table. And actually that's largely been the case through most of this effort. So what happened next? Well, in the House of Representatives, there's 3 committees that have jurisdiction over pieces of health care. And they actually came together and wrote one bill. This had never happened before, actually. They formed a tri-committee, and they wrote one bill, and that bill was introduced in July before the August recess, and they passed it in November. In the Senate, there's 2 committees of jurisdiction over health care. One is the Health Committee, Health, Education, Labor, and Pensions. That was Senator Kennedy's committee. And the second is the Finance Committee. And the Health Committee moved pretty quickly. Their bill was done by, I think, September or so, maybe early October. But the Finance Committee was a huge problem. And that was the place where the Gang of Six, which was, came out of, which was 3 Republicans and 3 Democrats who labored mightily to come up with some sort of bipartisan solution to this. And they, did it for months, and eventually they did get a bill out of the Finance Committee with 1 Republican vote, Senator Olympia Snowe from Maine, but she ultimately refused to vote for the final bill in the Senate because it had drifted a little bit more to include some of the elements from the Health Committee, which she was not in favor of. So it took a very long time in the Senate, and they finally had this historic Christmas Eve vote and passed the bill. Despite all of this incredible negative rhetoric that we've all been hearing for the last year, these bills really are about 80% similar. And it's the 20% where they're not that's caused all the conversation. So here are some things where they agree. Everyone agrees, both sides of the aisle actually, that there should be an individual mandate to purchase insurance. This is a really important issue because assuming that people will be able to afford it, and that's really where the rub comes. If we have a mandate to buy insurance in this country, then it will change the conversation that's been going on in Washington for the 200+ years that this country's existed, from whether or not we should have insurance for everybody or whether or not everyone should have access to health care, to how. Because when constituents can't buy or can't afford to buy health insurance policy, and they are now in violation of the law and they're being fined, they're going to call up their member of Congress and say, hey Joe, this does not fly. You need to fix this and make this something I can afford because I'm not a lawbreaker. I'm working 3 jobs here and I still can't afford to buy this thing, so you better fix this. And that will dramatically change the conversation going on in Washington in a really substantive way. So although the individual mandate's been somewhat controversial, I think at the end of the day, it will change future legislation in a way that will be very positive for people, although there probably will be some short-term pain from this for some folks. Everyone agrees, too, that there needs to be increased, well, to be totally honest, the Republicans don't totally agree with all of these greatly increased regulations, but they agree with some of them. And so what those regulations are is that people cannot be denied insurance for pre-existing conditions, nor can they be dropped when they are sick, and that's called rescission, and that's happening in the individual insurance market for people who own their policies themselves. They pay their premiums all year, but during that year they get diabetes. When it's time to renew that premium or that policy, they find out that that policy is no longer available to them. That would be outlawed. It would eliminate annual and lifetime caps that insurance policies promote, and that would help tremendously for mental health coverage. People with needing mental health services run up to annual caps, usually within a couple of months, and also certain chemotherapy drugs are now running into these caps. And then there's something called the medical loss ratio, and what that means is how much of every premium dollar actually gets spent on health care versus administrative tasks or CEO bonuses, that sort of thing. And right now, companies are spending around, and this is of course all private health insurance companies, 70 cents of every dollar actually on health care. They would now be raised and be part of law that it would be either 80 or 85 cents of every premium dollar would actually go to health care. And then the House wants to eliminate the antitrust exemption. And health insurance companies and malpractice insurance companies are not covered by antitrust legislation, which is why you see these really highly concentrated markets all over the country. Then everyone is very much in agreement on expanding coverage for preventive medicine and primary care. And there's significant money in both the House and Senate bill that would go into primary care and public health infrastructure. There's incentives for small businesses to provide insurance. There's creation of a health insurance exchange, which is like a marketplace, like Travelocity for health insurance, and tremendous support for health information technology. So people were very much in agreement. The White House and the Senate were negotiating a compromise final bill between the two houses that would have come out for a vote probably by now when the Massachusetts election happened. And in that election, Scott Brown, who was a Republican, was elected to replace Senator Kennedy. And that happened on January 19th. And that removed the 60th Democratic vote in the Senate. And in the Senate, you need 60 votes to stop a filibuster. And a filibuster is a way of having basically endless debate on a bill until there's 60 votes to stop it. And so you need those 60 votes for any type of bill that can be filibustered, otherwise it just never gets voted on. So that was a pretty critical event, and it really created lots of drama in Washington, D.C., to say the least, and a great deal of uncertainty about how to move forward on these bills. So there's been a lot of questions about what the Massachusetts election really showed, and I just wanted to share this one poll with you. There actually were no exit polls done because no one was expecting a Republican to win this seat. It just sort of came out of nowhere. But there was one poll conducted a couple of days later by this organization called Research 2000. And the results here are from people who voted for Barack Obama for president, and then they voted for Scott Brown, the Republican, or they didn't vote at all in this special Senate election. And they were asked whether or not the Democrats were delivering on promised change. And you could see yes, 31%, no, 57%. They asked whose side are the Democrats on? Lobbyists, 47%, versus people like me, only 23%. And then they asked of those who were opposed to the Senate bill, would you like, because the Senate bill does not have any sort of public option in it, the House bill does. Would you like the government to offer the choice of a government-administered plan like Medicare for everyone? And 82% said yes. So 82% of the people who either stayed home and didn't vote or voted for Scott Brown said they wanted a public option. So it's an interesting comment because Scott Brown is not for a public option. And so it's hard to really interpret all of this, and if people just, this is just too complicated for people to really internalize it, or people just fed up and disgusted with what's happening in Washington and they didn't want to see something happen, so they voted for change. But it's hard to know. So on February 25th, last week, the president had this summit. It was bipartisan. Some of you might have watched it on television. And a couple of days before that, on the 22nd, he posted his plan. This is the first time, actually, that the president has weighed in with a bill of his own. It was based on the Senate bill. It's very, very similar to the Senate bill. But he put in some sweeteners for the House Democrats to get rid of some of the things that the House Democrats were most opposed to in the Senate bill. So I'm just going to quickly go through some of these items. And the things that have a little purple check next to them, purple being bipartisan, are the things that the president proposed. So in terms of an individual mandate, both bills have an individual mandate in them, as does the president in terms of supporting that. The fines for not complying were much bigger in the House bill than in the Senate bill. The president took something that was kind of in the middle, oops, sorry about that, which was, which is down here, which is a fine of family maximum of $2,085 or 2.5% of family income, whichever's higher, phased in. Or I'm sorry, up to 2.5% of this, as long as it doesn't exceed that. So the president's penalty was a little bit higher, but would definitely support an individual mandate. So if there's going to be an individual mandate, people have to be able to afford to buy insurance. So there's a whole bunch of stuff on this slide, and I'm going to reduce it to this simple thing. The House bill had much better affordability provisions for low-income people. So these are people above Medicaid, but still pretty low income. The Senate bill, not so good for the lower-income people. And so what the president did was he took kind of the best of the Senate bill and the House bill and put it together so that he would end up with lower premiums for people whose income was less than $44,000 and greater than $66,000, and then he lowered cost sharing for anybody whose income was less than $55,000. And his compromise would make it so that 73 to 94% of all costs were covered for people who make less than $55,000 a year. So that includes the cost of the insurance premium itself, any co-pays or deductibles. So he really makes it so that pretty much everything's covered as long as you get your insurance policy. Employer responsibility. This is an area where there's a big difference. In the House, employers are mandated to cover or to offer insurance or pay a pretty significant payroll tax, 8% payroll tax on wages for all employees if they don't offer insurance. In the Senate, no requirement for employers to offer their employees health care insurance. And the original Senate bill had a pretty weak penalty for employers. And there was a great deal of concern about this, because if you did the math and you were an employer, it'd be much cheaper to pay the penalty than actually offer your employees health care. So there was a great deal of concern that a lot of employers would just simply drop the benefit for their employees. So the president took the Senate approach. There's no employer mandate, but the fees are much higher, $2,000 to $3,000 per employee. So that starts to get, starting to get close to what an employer might contribute for a health insurance policy. So it's going to change the equation for them a little bit, and does exempt any employers with fewer than 50 employees. Medicaid and CHIP expansion, it's expanded in both bills. The House bill would have taken eligibility for Medicaid up to 150% of the federal poverty level. In the Senate bill, it goes up to 133%, and that's where the president weighed in on the 133% of the federal poverty level. And this was where there was a whole bunch of controversy. Is anybody here familiar? Have you heard about this Cornhusker kickback? So that was a hugely controversial provision that got put into the Senate bill for the state of Nebraska, where I happen to be from. And what it meant was that the federal government was going to help pay for this expansion. So let's say a state was at 100% of the federal poverty level now, and now under this new rule you'd go up to 133. The federal government was going to help pay for that for the first 2 years, the whole thing, and then a piece of it in out years. The Cornhusker kickback was that the federal government would pay for Nebraska that expansion piece forever, in perpetuity. So nobody else really thought that was very fair, including a lot of residents of Nebraska. So Senator Nelson, who proposed that, got a lot of grief, and he's actually now asked for that to be withdrawn. So what the president did was, he said, we're going to do 100% federal match from 2014 to 2017. It would start in 2014. So 100% payment by the government for the first 3 years. Then it would go to 95% from 18 to 19, and then 90% from 2020 and beyond. And that would apply to all states. Both bills set up an insurance exchange. The big difference here is that the House bill would have made a national exchange. So it would be one big exchange, one big marketplace. The Senate bill requires the creation of 50 state exchanges. So the insurance pools will be a little bit smaller, may not bring costs down quite as much. There certainly won't be as much competition, but this has been a very controversial issue. So the president, again, having based his position mostly on the Senate bill, went with the state-based exchanges for individuals and small businesses up to 100 employees. That's who could buy their insurance through the exchange. Or if your employer doesn't offer it, you can buy it through the exchange. But he does want these exchanges administered by a government agency or by a nonprofit, because there's a great deal of concern that with these state-based exchanges, in certain states, private health insurers have a really quite a bit of political sway with state legislators, and that they would kind of co-opt this in a way that's not in the best interests of the citizens of the state. So the president weighed in that this has to be run by either government or a nonprofit. The public option, a hugely controversial issue, was in the House bill, is not in the Senate bill, and the president has stuck with that. He would establish, though, a health insurance rate authority that would provide federal assistance and oversight to the states to conduct reviews of unreasonable rate increases or other unfair practices. Now, some of you may be familiar with the fact that last week, actually a couple of days before the summit, Anthem Insurance Company in California, division of WellPoint, raised the rates in California by, for some folks, up to 39%. Now, why they picked that week to announce that kind of a rate increase was a very interesting strategy on their part, and a pretty foolish one. And I'll tell you, I think that that act alone is going to be one of the biggest game changers in this whole healthcare reform effort, because people were becoming complacent. The advocate community was exhausted. Everybody was so tired. And when they did that, when they announced 39% rate increases for people, these are people in the individual market, talk about re-energizing the advocacy community and everybody else, and the president. The president was furious about this. So very, I guess, foolish, actually, on their part, assuming that they didn't want any of this to pass. So we'll see. Then there's the issue of the abortion reproductive rights language, and the President's Compromise Plan says that there have to be at least 2 multi-state qualified plans in each exchange, and qualified means that it offers a minimum set of benefits that are decent. And at least one of them is nonprofit, and at least one does not cover abortion services. So this is one way to keep federal money from subsidizing abortion services. We can talk more about that later if you're interested. And so this is just to give you some general numbers. The difference between the House bill and the Senate bill really do actually matter in terms of how many people get coverage. If we do nothing by 2019, it's estimated we'll have around 54 million people without health insurance in this country. Under the Senate bill, we'd have 25 million remaining uninsured and about 17 million under the House bill remaining uninsured. Of the 17 million, about 7 million of them, and in this 25, are people who are here in the United States illegally, and then the remaining are people that just are felt won't be able to afford the coverage available to them even with the subsidies. So I mentioned undocumented immigrants. In the House bill, well, first of all, in both bills, no undocumented immigrant would qualify for any sort of help in purchasing insurance. But in the House bill, if you could afford to buy it on your own, you could buy it through the exchange. In the Senate bill, which is where, and the President was silent on this issue, so we're assuming this is where he's at, you actually have to show proof of citizenship to buy a policy in the exchange. So that's where we're at with that. Both bills would, I'm sorry, the House bill would close the Medicare prescription drug donut hole. The Senate bill would not. And the President, I think, is weighing in on closing the donut hole. So I think we're very likely to see that in the final legislation. Big increases of money for primary care and all sorts of primary care providers, not just physicians, but nurse practitioners, nurses, health aides, the whole picture, which we all know that we desperately need. And both bills would actually redistribute for physicians some unused residency slots toward primary care. They increase scholarships and loans for physicians and nurses who commit to careers in primary care. And there's a lot of money for public health and public health infrastructure. In the Senate bill, $25 billion over 5 to 10 years that would go into public health and wellness strategies, community health centers, and workforce. The President actually weighed in with $11 billion specifically to build more community health centers. So that's really good news. The physician payment system is going to move away from our current fee-for-service reimbursement, where basically physicians are paid to do tasks or things rather than paying for quality. So we like to say our current structure pays for quantity, not quality. And there's a lot of language in both bills that would move us towards starting to pay for quality instead. And these are very, very important steps that will ultimately and hopefully change how much healthcare costs in this country, and we'll certainly be getting more for what we pay for. And then in the Senate bill, there's another very important thing, which has also been very controversial, which is an independent Medicare commission that would advise on Medicare payments to hospitals and doctors, and it would have the authority to implement Medicare payment changes. Currently, Congress actually votes every time there's a fee schedule change. So you can imagine the lobbying and the politics and everything that goes on every time there's a change in the fee schedule. In fact, Medicare proposed some changes to how cardiologists are paid recently, and the American College of Cardiology sued CMS, the Center for Medicaid and Medicare Services, because of these changes. And the suit was dismissed, but this happens every single time. There's like constant lobbying. So this board would be sort of like what the Fed has, a kind of a separate board that would be a little politically isolated that could make recommendations. And then a lot of money going into comparative effectiveness research to help doctors and nurses understand more clearly which treatments are the most effective. And would take some money away from Medicare Advantage plans, which are Medicare plans that are run by private health insurance companies. And they cost about 14% more than just regular Medicare plans. Now they do offer some other benefits, but they tend to be benefits like guaranteeing a private room or health club memberships or better support for vision services, that kind of thing. I mean, not that some of those things aren't important, but they do cost quite a bit more than regular Medicare plans. And so both bills would scale back Medicare Advantage monies. So bottom line in terms of revenue, the House was predicated, the House bill, on a surcharge on income. That was really the most important point. If you made more than $500,000 a year as an individual, or more than $1 million if you're filing jointly, there'd be a tax on that. In the Senate side, which is where we're going to end up, it was mostly predicated on an excise tax on group health coverage that's in excess of the policy has to cost more than $8,500 for an individual or $23,000 for families. So these are these high cost policies that everyone's been focused on. And that's also been very controversial because a lot of these folks are people like policemen or firemen who are in very high risk jobs, and so consequently they have very high risk health insurance or high cost health insurance. And some of these are people that are part of unions who have negotiated more generous health care benefits in lieu of wage increases. So this has been a very controversial thing to tax these plans. The president feels very strongly that it's an important component. So his compromise is he pushes it out to 2018, so even if he gets reelected as president, he won't be president in 2018, very smart, and raise the amount of money. So for an individual, it would be a plan that costs $10,200, and for a family, a plan that costs $20,500. So we'll see what happens with that. And then the president also adds in a 2.9% tax on unearned income, like interest and dividends, that would be part of the revenue stream here. And there's a whole lot of other little things. So this is probably one of my most favorite cartoons I've seen this year. The most frustrating thing about healthcare reform is asking for a second opinion. So what I just showed you is the Democrats' plan. The Republican plan, I just have one slide because there's really not much to talk about in terms of formal plans. There's no plan out of the Senate. There's 2 plans in the House, maybe 3, depending upon how you want to count it. The Congressional Budget Office, which is the nonpartisan body that decides what things really cost, how much money these plans will really save, believes that the House Republican plans would extend coverage to about 3 million people versus the 30 million people that the Democrats' plans would extend coverage to. There's no individual mandate in the Republican plans, even though that was something actually that John McCain campaigned on. So it's just interesting how these things flip-flop. They would produce or offer tax credits to small businesses and individuals to encourage purchase, and they would expand state high-risk pools for people who couldn't afford insurance. Right now, today, state high-risk pools in the whole country insure about 200,000 people. So whether or not that's a real strategy that would actually help people isn't clear. They would also allow insurance to be sold across state lines, as does the Democrats' plan in the exchanges, but the difference is in the Democrat bills, there are minimum benefits that those plans have to offer. In the Republican plans, there's no minimum benefit requirements, nor would these plans have to comply with state benefit requirements. And so the current concern is that there are some states that have very few mandated benefits that insurance companies would actually relocate and put their headquarters in the states with the lowest benefit requirements, and then those would be the plans that they would sell out across the country, so that, you know, possibly some of these plans would actually be plans that cover very little, so that people wouldn't necessarily be getting the coverage that they thought, and it would go back to that issue of uninsurance or underinsurance, where people thought they were covered but they really weren't. And these plans don't have any new regulations in them, like the whole thing about not denying for pre-existing conditions or not being able to drop people once they get sick. So all of that adds up to the fact that only about 3 million people are estimated to actually get coverage under any of these plans. So next steps for federal legislation. From the summit, the president decided to include 4 Republican ideas. He announced this yesterday. $50 million for state demonstration projects to reduce malpractice. He'd already put about $23 million in for that, but he's going to put in another 50. Improved Medicaid reimbursement to physicians. This is actually pretty important because Medicaid reimbursement, particularly for primary care, well actually for all physicians, is really, really low. And it's quite difficult for people with Medicaid to find a doctor to take care of them. So the hope here is to raise Medicaid reimbursement to Medicare rates, in the hopes that this will actually improve access for people. The president has said that it's okay to sell or include health savings accounts in the exchange. These are actually pretty good for really high income people, but they're not so good for people that don't have who can meet these high deductible plans that go with them. They're usually like $5,000 or $10,000 deductible plans, which if you're really wealthy, that may be fine. But if you make $30,000 a year, that's not going to work so well. And then he supports this idea of random undercover investigations to reduce fraud. Now, I got to tell you, the idea behind this is that you would take physicians and nurses and they would pose as patients and go see doctors. And if that doesn't undermine the doctor-patient relationship, the thought of looking at a patient every single time and wondering, is this really a patient? Or is this just, you know, somebody, I don't know, but he was willing to put that in. So, next steps, here we are. This is the current strategy if we're going to move this thing forward. The House can pass the Senate bill tomorrow, and it can go to the President's desk, and he could sign it on Friday. So we could do that by Friday. The only reason that hasn't happened is the House has some really specific concerns about some of the elements in the Senate bill, which I talked to you about. This Cornhusker kickback, the affordability for low-income individuals. There needs to be this compromise that I mentioned on taxing the high-cost health insurance plans and closing the Medicare donut hole. Those are like deal breakers for the people in the House. So that brings us to this thing of budget reconciliation. The House, I think, will be willing to pass the Senate bill, assuming that the Senate agrees to pass a fix-it bill. And that would have to be done in the Senate under something called budget reconciliation, and I'll explain that in a minute. So this budget reconciliation bill will include things that are affecting the budget. They can only affect the budget. So things like the abortion language, for instance, cannot be in budget reconciliation. And it would fix these 4 things, all of which definitely affect the budget. And the House has to originate that bill because the House has to originate all bills that have to do with the budget. So the House would originate this bill and pass it. And then it would go to the Senate and hopefully be passed. Then the President signs the original Senate bill, and then he signs the budget reconciliation bill, which modifies the original bill. Got that? Doable. Several step process, but doable. So this actually, I found this cartoon today. The President saying, you appear to have an obstruction, and we may have to do a bypass. So what that bypass is this thing called budget reconciliation, and it allows for no filibuster consideration of legislation affecting mandatory spending programs or taxes. So the difference here is, I remember I told you need 60 votes to block a filibuster. A budget reconciliation bill needs 51 votes to pass. So it's a simple majority rather than what's called supermajority that 60 vote threshold becomes. So what's been passed under budget reconciliation? Well, some really important things. COBRA rules were created under this in 1985. Welfare reform in 1996. The Children's Health Insurance Program was created using budget reconciliation in 1997. So was the Medicare Advantage program, which I talked to you about a few minutes ago. In 2001 and 2003, the Bush tax cuts were passed using budget reconciliation, both of which increased the budget deficit. So in 2007, Congress passed a rule that you can't use budget reconciliation to increase the deficit or the national debt because of those 2 tax cuts. So none of these things I talked to you about would increase the debt. In fact, the Congressional Budget Office has said that all of these bills will absolutely reduce the federal deficit over the first 10 years and even in the out years beyond that. But you can still filibuster amendments to the budget reconciliation bill, just not the bill itself. And so it's not clear if this is going to be able to get through the Senate or not. So we're just going to have to see. In the meantime, the President's done a bunch of things with his 2011 budget that he's put in to try to help this process along. One is money for federally qualified health centers, public health workforce and infrastructure, money for health information technology, comparative effectiveness research, school meals and childhood nutrition programs. You've, I'm sure, heard that Mrs. Obama has started a whole obesity program, which is great. Money for the National Health Service Corps and expansion of HIV/AIDS treatment, care, and prevention. And the House of Representatives actually did revoke the current antitrust exemption last week. So it's not clear if the Senate's going to vote on that or not, but the House has at least done it. And then we're already starting to see state-based things happen. So this is my canary in the coal mine. In Virginia, on February 1st, the democratically controlled Senate passed a bill that said it would be illegal in Virginia to require individuals to purchase health insurance. Now, whether or not this would trump a federal bill isn't entirely clear yet. It probably wouldn't, but states are already starting to tee up these bills that would try to undo whatever the federal legislation is. So I think I'm going to stop there in the interest of time. Physicians, though, I'm going to just make one more comment, have to some extent been all over the place, but for the most part have been together on this. And this was an ad that we actually helped put together, 14 organizations that represent a total of 500,000 doctors with their combined membership. And they're about somewhere between 700 to 800,000 practicing physicians in this country. No one's actually really sure exactly what that number is. But I'll just leave you with this thought. So I'd be happy to take some questions.